Good morning, viewers. Today we are at IPA Con 2024 AP and Telangana chapter Hyderabad. With me, the General Secretary of IPA Con 2024 AP Telangana chapter, Dr. Reginold, Dr.Anurag, Chitranshi is a very important member of the core committee, and Dr.Varun, Vishwanath, we have just reached today. These are specific some workshops. Sir was busy yesterday. So we will going to have some discussions and some feedbacks. Yesterday was very exciting. I have seen a lot of delegates are there. But sir, what is that motivated you plastic surgeons to be into this podiatry? So if we just can have all of your views.
First of all, we understand the basic depth of the problem. For every 20 seconds, one leg in the world is getting amputated. And those who are getting amputees, 50% of them don't live beyond 5 years. And again, the burden to the government or the burden to the individual is quite high. It goes into some hundreds of dollars of money in US. And then a scientific paper recently presented says, in India, if at all a person is having a diabetic problem, he invariably ends up spending 1/3 of his earnings, his total earnings, 1/3 is gone only for diabetic foot problems. So this is a very huge problem which we are facing, particularly in countries like India where the population is high, and India being the capital of diabetes and Hyderabad more so becoming the capital of the world for diabetes. We are seeing so much of problem. So we are interested to get into the society to do something good as doctors to the society and try to decrease the burden or financial burden and try to give good health to all these people. If at all we can take that message to them, then if they can take some precautions without getting amputated, if they can come for regular checkups and save their feet, there will be lots of change in the society and individuals.
In fact, yesterday I was remembering you was telling about MDT, multidisciplinary team approach, which is very important.
Yes.
Because there is always a link gap between the top level, the plastic surgeons and the primary care physicians. So how do you think you are going to bridge that gap?
Definitely, diabetic wound management requires experts from various specialities to give ultimately the best care to the patient. And we fit a particular slot in that as plastic surgeons because we have been handling wounds since a long time. And along with the physicians and the vascular surgeons and the general surgeons and everyone, we can be a part of the team and contribute to a better outcome in diabetic foot wounds. So that's how I feel the MDT concept really works well for the patient in diabetic foot care.
And if you see, our delegates are from general practitioners, GPs to plastic surgeons, like including our physicians, general practitioners, then orthopedics, and then we have a lot different people sitting out there. So because if this particular knowledge percolates with the GPs, and they know when to refer the case to which specialty, either it has to go to a vascular surgeon, or it has to go to a plastic surgeon, or it has to go to a podiatrist or an orthopedician who's doing a charcot joints. That is very important.
Sure.
See, this has to percolate into each and every individual in the ecosystem of diabetic foot wound care.
So it should be done. So because the knowledge that most of the limbs can be saved, and it's like orthopedicians should also know which one, when to send it to plastic surgeon, everything. So even the manufacturers of for soft footwears for them. And when coming to plastic surgery, we try to improve the blood supply and save the limb. So the knowledge should go on to most of the practitioners, general practitioners, that most of the limbs can be saved, need not get amputated.
Sir, I have experiences. It's very similar to you. Being a director in the Quorit Academic Foundation, we have dedicated a lot of time for the research of new products. So we primarily focused on the dressing parts, the development of drugs. But during our different workshop, what I've realized that in most of the cases, the final treating consultant, he may not be think about a no coordination with the physicians, where the primary cause is still not controlled. Like in diabetic foot, the patient has the chronic wound healing, but his glucose level is not controlled, and there is no coordination. So this is somewhere I believe that message should be that there should be, we work as a team. There is a role of the paramedical staffs, also the dressers, the physicians, the plastic surgeons.
So basically, nowadays in corporate segments or in high segment hospitals, they have a team starting up from paramedics to plastic surgeons, everybody, the nursing staff who are dedicated into diabetic foot. So the team is happening, but at an individual level, the teams are not existing. So, but then again, we have a synergy between ourselves. We try to send to a physician and or to a orthopedician because we recognize what exactly is happening, what is to be done. But I would like to actually congratulate you for your app which you have launched yesterday.
Thank you, sir.
That app is worldwide, and then it is connecting so many different physicians or the surgeons on the worldwide basis. And it basically helps us to understand the wound, whether it is healing well or not, and all those things. And the best thing what I found is, if at all somebody is having some doubt, maybe in a remote place like Nigeria or maybe in Uganda, they can direct that particular wound, and then they can discuss with surgeons like us in Hyderabad or wherever it is.
Exactly. That was basically the objective, to create a platform where the consultants and different faculties, they can exchange their thought process and they can consult them each other for the benefit of the patients. That is the concept of this academic foundation, to provide a comprehensive management approach.
And it is like in chronic diabetic ulcers or food diseases, usually the patient complaints also matters. It is because he might have visited many other people, and
Right.
the patient irregular treatment part, there should be a confidence for the patient that it's going to heal up, and the regular follow-up of the patient. Sometimes we need to follow up the patient, and patient needs to clarify the doubt. He might try to contact us. So this communication should decrease. We should be always going on like in the regular follow-up for that patient, and then the hope increases, and your products are really doing good. So increasing the all the blood supply and all these things, good one actually. So the main thing is like a patient confidence, and his regular follow-up matters as far as diabetes is concerned. So most of them, they do come for some time and then irregular thing, and there are some other family issues might be there for the patient, or the cost issues might be there for the patient to come to a doctor. So these all things do matter.
Sir, today you are actually taking a very interesting topic, secondary surgical wound lesions. Right?
Yeah.
So, sir, can you just put light, because I was there in Uganda in September, and we see a lot of patients of secondary wound lesions.
See, it's a thing which we hate to admit, but then it happens. So when we do take stitches, they do open up sometimes before we want them to. So, but then when it happens, what do we need to do? That's something which all of us should know, and all of us should approach cautiously and be aware of it. So that with time we are able to get better outcomes in it. So many times it may be because of the general condition of the patient, which is not optimum for that surgery. Many times we fail to use the correct techniques for suturing the layers which we suture for the surgery. Sometimes the post-operative care after the sutures have been taken may not be the appropriate wound care for it. So all these aspects have to be taken care of to get the best outcome.
Sir, SSI also plays a very major role here.
Absolutely, surgical wound essence and SSI are they are one after the other. Like SSI can cause surgical wound essence, and surgical wound essence ultimately lead to surgical sites infections. So control of both factors affecting both will give a better outcome ultimately.
Just to give you a latest update, sir, worldwide consultant like you don't want to use more of antibiotics for that. So we have already developed one nanosilver with vitamin C gel, and we are also invested ourselves to develop some peptides which change the bacteria's structures.
True.
So that's we are on the process with some of the international institute.
We're looking
That is
forward to it.
Sir, what about that second injury? They have now recently started talking a lot about second injury. Around 70% patient associated with trauma and pain associated with the dressing change. We cannot deny the fact that gauze is the still widely used secondary dressings. Right.
Definitely, see, one thing may lead to another. Sometimes patients develop wounds because of improper care in the post-operative time. So maybe tight bandages or use of inappropriate dressing materials also may lead to some secondary ulcers. So that also is one big concern, and we need to educate people to use the correct products for wound dressings and take the correct post-operative steps to prevent such transfer wounds or secondary ulcers or whatever you may call it.
See, even if it's a diabetic foot wound, though it sometimes looks dirty and all the thing, but the sterility of approaching that wound is like, as surgeons we actually understand the importance of having the sterilized environment and the sterilized way of treating the wounds. That's one. Second thing is again applying the bandages. We also understand there are certain pressure points where we are not to put too much of pressure of the bandages because either because that it causes some sort of an ulcers there. And so these things are anyways there. I think that is a good teaching what as plastic surgeons we really have.
The type of dressing depends upon the wound. It is not universal for each and every patient.
Exactly.
Depending upon the wound, what should we use? Use the gel and with the particles and collagen particles and all those things. And pressure is the main factor. Or the sir said, it is like should not be too tight. Like they put up a tight crepe bandages and then they so it's all completely patient dependent, and this is the stage of the ulcers and the diabetic foot it is.
So yes, actually there is a recently available, let's see, non-adherent dressings. Very simple. It's not impregnated with Vaseline or any medication or products. It is simple polyurethane, non-adherent, porous mesh launched them. I think can it be helpful to reduce that trauma parts if they started applying it as a fast layer? But I just want to know from you that immediately. Although, as per protocol for the clean wound, we should not require any, antibiotics or gel. But practically, what we have seen that they are using either mucosin or betadine or chloroxine.
On clean wounds, we actually use a non-adhesive layer, like bacterial gas or whatever it is. Then we try to put something further on it.
Yeah.
So if at all we have something better than that, obviously we'll be interested.
It was not coated with any of the drugs because actually what we have really feel we are already using something, so there is no need for other antibiotics or that like that. So we put it in a very non-pathogenic, sterile, non-allergic, wound protective mesh, which we call as a Curo guard. And what we have, our objective is that in Indian context, economy is an issue. Still, a lot of patients cannot afford that advanced wound care therapy. The objective of this academic foundation, how to bring those products in a more economic, affordable manner. And that was the reason we want to bring it so that every single patient can afford. At least, before putting the gauge, if they can put it, at least we can reduce the chances of that. So what your...
That's what I'm saying, that every dressings we do, a non-adherent layer is an integral part of any dressing we do.
Okay.
So we would always prefer to have one of the layers which is directly in contact with the wound, not stick to the wound, so that the time when it is time to remove the dressing is non-traumatic and is more comfortable for the patient. So yes, that we welcome that product which can serve that purpose.
So one more thing, how do you deal with the trauma? How will you deal with the edema? The edema.
Edema, there are a couple of things, basically whether it's a dependent edema and all the things, if it is in the foot elevations and proper support system will cause. Second thing is if it's lymphatic, we need to milk it out actually. I have, in my own experience, I've seen it that if at all, I suspect sometimes the edema may not be a simple edema, but it could be because of lymphatic edema. So there I
need to
try
do
some
drain
sort of a massaging sort of a thing, and which certainly helps.
But sir, what I have seen that most of the surgeons do not want to open a second wound. They don't want to drain out. And most of the cases what they do, uplifting that foot. But that takes a time. Patient get restless. Maybe in government setup it is not true, but in private setup, patients say, why I am not getting that responses. So what is your message from them?
See, whether we intervene, it's a take of the surgeon when to intervene and when not to do it. A surgeon is the one who can decide upon the condition when to put an incision, whether he has to put a fasciotomy or not, or just go in for limb elevation. See, in a day-to-day activity, as we keep seeing the patient, if at all it is too delayed and if we suspect there is some sort of infection, obviously we go for fasciotomy. Maybe there is some cellulitis, we go for fasciotomy. But if not, then the edema usually goes down. Other than the local factors, there are general factors which cause edema also. That also we have to rule out about the proteins or the renal parameters or the cardiac parameters. All these things to be done. End of the day, it is a holistic approach to the patient.
You know, there are certain composition available into the market like rutosate, bromelain, trypsin, double dose. It's a very regular use. In fact, being a part of a company, you also promote it.
It is one other part of the.
But do you really think that works?
Yeah, of course.
It works.
Yeah, it also works. It's a part of the treatment.
Yes,
it's a part of the treatment.
Integral part of any post-operative care we give to the patient. So, out of all the measures we use for reducing post-operative edema, trypsin, chymotrypsin, bromelain, and rutoside preparations also part of our system to reduce the post-operative edema.
So, dear viewers, we have now with us the three most prominent plastic surgeons as experts. So through app, you can actually reach them. Whatever you have confusion, you want to consult with your patients for your patients, your case, you can directly have access to them through our Quorit app. Please feel free. Let us make it a successful platform where there should be exchange of knowledge and we can develop more and more newer protocols. Sir, I want one single messaging from all of you for our viewers.
We prevent amputation.
We prevent amputation.
We prevent amputations.
We prevent amputation. Thank you.
Thank you.
Thank you.